We are joined by Dr. Steve James, consultant anaesthetist at King's College Hospital. You might remember Dr. Steve was the guy who confronted Savid Javid, or didn't so much confront him, but answered a question that Savid Javid, the Secretary of State for Health, asked him about what do you think about this vaccine mandate, which of course they said they wouldn't do, but now they are doing, and they're about to fire a bunch of people from the NHS, which is already short of staff, because they won't be vaccinated. Dr. Steve is one of those people. We're going to get his side of the story, and we're going to find out as well how he's been treated by the medical establishment and what's really going on inside of the NHS and in those COVID wards, because we don't always hear what I would call the unvarnished truth. You're going to hear it right here on Talk Radio, because you know that's where we tell you it's the truth, the whole truth, and nothing but the truth. So keep your ears open. Watch us as well on TV. 0344 499 1000. This is Talk Radio.
The Independent Republic of Mike Graham on Talk Radio.
Now, I'm delighted to say it's time to welcome Dr. Steve James. Steve, thank you very much for coming in, for joining us. There's so much to talk about, really. First of all, I suppose we should start with how it was that you came to be working in King's College Hospital on the COVID wards, and what that's actually been like for you as an individual.
Yeah, well, my background was as being an anaesthetist, but when the pandemic first sort of struck, we were asked who would go in and help support the ITUs with the increase in numbers. I volunteered then and have been working almost solely on COVID-based ITUs since then.
Right, and has King's College Hospital been pretty much at the forefront? We know that Guy's and St Thomas's, which are just around here with us. I walk past Guy's every single morning, and St Thomas's is where the Prime Minister was taken, of course, that night when many people thought, my goodness me, is he going to come out in the morning?
Yeah, so King's has had a very high number of patients come in with COVID-19. Our ITUs increased many-fold in size. The acuity of the patients who come into King's is particularly high compared with the rest of the nation. So people were at the forefront of it.
Yeah, it's a very difficult disease, it seems to me, to kind of figure out, especially for people like myself who are, lay people who are not medically qualified, because it seems to affect very many different people in very many different ways. We get statistics which are thrown at us, not so much now as they were, but we still get a daily kind of tally of how many people have died, how many people have been infected. People argue about whether we're testing too many people. Mm-hmm. Others say that actually, if you were not over the age of 80, you were pretty much okay. There weren't that many deaths. What's your take on the way that it's been presented to the British public, if you like?
So, I understand the initial reaction of concern with numbers going up and the necessity to change the way the NHS was running in order to cope with the numbers people were presenting. And there's been a huge shift required for that. But I believe we're now into a different stage, and I think we need to look at how the rules now reflect the current situation on the ground.
Was there ever a time when you were working when you thought, Christ, this is just going to be a disaster, we're overwhelmed, we can't deal with it, we've got people in ambulances outside, we haven't got enough room inside? Was it ever like that?
King's was pretty dynamic in the way it adapted to the situation. And I'm not a spokesman for King's, but I saw a brilliant team of people always finding the next ward, the next space, the next oxygen supply. What I was very conscious of at the time, and it's sort of come to bear through some conversations, is the weight put on the nursing staff, who even some junior members of staff from critical care backgrounds, people without a critical care background, were drafted in order to help, and they were quite heavily burdened with the amount of care they had to deliver. And that was simply very, very tough on a number of them. And
we saw at the beginning an awful lot of people talking, and the reason I ask the question in this way is because it's always difficult, because there are political people within the medical establishment, the BMA, whenever I hear them speak, I'm never sure they're speaking completely and utterly candidly about the situation. They're speaking from their perspective. An awful lot of people that I would suggest were working in ICUs as a matter of choice were complaining that it was horrible, that it was awful, that they were seeing people dying. To which I would always say, well, you work in an intensive care unit of a hospital, isn't that what people go in there to do?
Yeah, it is what you go in there to do, to look after people in those situations. But we're used to a certain standard of care, a certain ratio, for example, of nurses to patients as a sort of very basic point. And the usual thing on ITU is it's one nurse to one patient.
Right.
Well, during the pandemic, it was often stretched to 2, 3, and sometimes 4 patients per nurse. That's incredibly hard to be able to deliver the right care that you know those patients need.
Right. And of course, at the beginning, in the first sort of months of 2020, when the first lockdown happened and you were treating people, there were no vaccines at that point. So it was a sort of dangerous occupation, perhaps, for you. I mean, I know that an awful lot of people were worried about COVID. They didn't know what it could do to them. They didn't know whether they could pass it on to elderly relatives, which is why they all behaved in a particular way, and they all did kind of adhere to the lockdown. Was there any point at which you thought, I'm actually putting myself in physical danger here?
I didn't feel afraid of COVID myself. I moved my family away from where I was living because we'd heard from colleagues in Italy that they were self-isolating from their families because it was so contagious.
Right.
But what I heard very early on was how it's affecting the elderly and how it's affecting those with comorbidities.
Yes.
I started watching and looking at who came through the door. Maybe because I came to ITU with a new set of eyes, I was, trying to get my feet on the ground and see what was going on. But I've been watching and looking, and I haven't seen a single patient turn up in intensive care who hasn't got comorbidities at King's, and I haven't come across a colleague who's seen one as well.
And that's one of the things that I think a lot of people have got issues with the way that the statistics have been rolled out, where Chris Whitty at times would make it seem as though everyone was in danger and everyone was at the same risk, when that was clearly not true. I mean, in terms of the numbers of people who've actually died from COVID, having not been tested positive in hospital, having gone in with something else, we still don't really know the true figure on that.
Yeah, I mean, it's a difficult number to obtain. So there's this process of looking at who's died within 28 days of a positive PCR test, and some of those people won't have died from COVID, but there will be some people who'll have died after day 28 and will have had a COVID-related death. So there's going to be a bit of balancing there. But there's a death certification program system, and on that, the junior doctors, usually guided by a consultant, look at what they put down on a death certificate. Right. And what I've noticed is that it's quite often that we miss as medics low-level obesity, so obesity where the BMI is a few points over 30, and we certainly wouldn't document a patient as being overweight. I think it's become common in hospital to only mention obesity when the obesity is really quite dramatic.
And so, I mean, overall, would you say that the vast number of people, in your experience, who have died from COVID, whether or not they caught it in hospital or not, were older, more obese, likely to have suffered from something else? Because if they weren't any of those things, it's a much smaller number, right?
Indeed. So if you look at, and that was my experience completely, and if you look at the CDC, then the director stated recently that 75% of deaths in the US were with patients who had 4 or more comorbidities. Right. So out of that other 25%, a good chunk have got 3, a good chunk have got 2, and some will have 1, and a very small number will have 0. I was looking through the statistics this morning from the Office of National Statistics and trying to work out how many patients have died roughly in different age groups per hospital. And we've got about 950 to 1,000 hospitals, I think, in England and Wales. Right. And there have been about 4,000 deaths in the age group under 65 who don't have any comorbidities. If you look at how many of those would probably have occurred in the under 50s, then it's about 1 patient per average who's died in each hospital. And I think
over the whole period?
I should state that up until September 2021, which is the last date at which the statistics are available.
Well, that's well over a year, though, isn't it? A year and a half.
That's the 2 main peaks.
Yeah, which is an extraordinary number, which I think if we'd known earlier would have been much more informative than what we were told about, because we've now been told that the CDC has, for example, removed the use of PCR testing, because we've heard an awful lot of the testing that is done is providing us with a false picture of more people with COVID than actually there are.
Yeah, because if you test with a PCR test on an asymptomatic group of people, then what's called the false positive rate, which is how often it shows a positive test even when it's not true, it's a very small percentage, but if you apply that to a large population of people who are asymptomatic, you'll get a certain still significant number of people who test positive. Out of that same population, the people who are asymptomatic and have actually got COVID are smaller. Right. So if you're asymptomatic and you test positive, the data I've been shown shows that you're more likely to not have COVID than have it.
Well, exactly right. I mean, I actually asked the question about probably a year and a half ago. You know, if you were explaining to somebody who'd come here from Mars, you know, we've just tested that guy over there with symptoms. With symptoms of COVID, and it's tested positive. We've just tested this other guy with no symptoms of COVID, and it's tested positive. What are the chances that the test is wrong and he doesn't have COVID, rather than the fact that he has COVID and he doesn't have any symptoms? Because the logical answer to that is, well, he probably doesn't have it, isn't it?
Yeah, I mean, that's what the statistics show.
So is it possible that asymptomatic COVID doesn't exist? It's possible, right?
When you say it doesn't exist, you mean that the person hasn't got the virus in their body?
Well, I mean, the fact that we are told that you can have COVID but have no symptoms.
Well, I think the thing to say is the difference between having the virus and having COVID. So COVID-19 is the disease process caused by the virus. So you can be a carrier for the virus.
Okay.
If you're a carrier for the virus, have you got COVID-19? No, not necessarily.
Right, but you could still infect somebody else with it, I suppose.
Yeah.
Right. And so when did you get COVID, and how bad was it for you?
Well, over the whole period of the pandemic, I've had one fever which lasted for an evening, went to bed, thought, oh, I've got it now, woke up in the morning and was fine. And then the following week I tested with a PCR and was negative. I don't know when I've actually had it,
right.
But I did an antibody test before Christmas and I've got antibodies, so I've been exposed and I've got...
And the government, of course, have been very sort of strange about antibody testing, haven't they? I mean, I did an interview with Savid Javid and I said, why are you not more reliant upon antibody testing, particularly in places like care homes? And he said, well, the trouble is that you can't really measure the size of the viral load because it's not possible to know how that person got infected, and if they did have COVID, how strong the viral load was. And it was kind of like, we don't really want to know about that. Why do you think they're not doing it?
I think the benefit of the vaccine for people who are at risk of COVID and the reduction it's brought about in the number of patients who are dying from COVID and having serious disease from COVID, and it's a massively important point. It's not to be ignored, but it's become the sole focus of the way the response to COVID is being delivered. So people are not seeing the wood for the trees anymore. They're just seeing vaccines worked really well in this group, so we must do more vaccination, and more vaccination must be better. And if we vaccinate the NHS staff, and if we vaccinate this group or that group, or we put pressures on people. So if I think about my friends who are not medics, I don't know a single one who wanted the vaccine. Most people took the vaccine because they felt on a balance of shall I have it, shall I not, in particular because they want to be able to travel. They took the vaccine for that reason. Right.
And of course now they're seeing a change in policy in which it might be necessary to take 3 vaccines rather than 2, and then maybe 4, and then maybe 5. And I mean, that I think for a lot of people is slightly worrying. That's why I think the booster rollout has been slower, because some people are going, well, hang on a minute, you know, you told me the first 2 were going to be enough, and now you're saying they're not. But what's the reason you haven't been vaccinated? Is it because you fear that it might not be good for you, or is it simply that you don't think you need it?
Well, it's a combination of things. So, you know, when you make a decision about a medical intervention with the patient, you're kind of weighing up 3 things. One is the risk of having the treatment or not having the treatment. One is the benefit of having the treatment, and the other thing is how you as an individual weigh those things up. So for me, I'd rather in general go for a natural health approach for myself, rather than give some sort of reliance towards a pharmaceutical intervention. I don't see the risk as being significant for me having the virus. I had it at some point, barely noticed I've had it. And what's the risk? Well, it's not the same as having some saline injected into the back of my arm. There is a chance. I've got colleagues who've had significant medical problems as a result of the vaccine, and we haven't got 20 years of data on it. So, yeah, it just doesn't make any sense.
And it has caused injuries to an awful lot of people. And one of the questions I often ask is, why do we not have enough data on the kinds of people who are becoming injured by the vaccine? Because there must be something they have in common. I don't think it's just a random situation where some people are allergic to it or some people react badly to it. They ought to presumably be able to collect data to say, well, these people who suffered as a result of being vaccinated have something in common. Could we not see those data?
Well, there are some questions about whether the data is being produced and made available quickly enough. It's not an area I've particularly focused on, but to me it seems that we knew COVID was going to take this kind of course, for example, there was going to be questions about death rates from COVID from the beginning. We knew that if a vaccine was developed, people would want to know nuanced data about the side effect profile so they could make an informed decision. So I'm surprised that there hasn't been a greater process, because if it's as safe as we are generally led to believe, and it is a safe vaccine in the sense that the chances of you having a serious outcome that's negative is much, much lower than the positive. Yeah? But that doesn't mean for everyone they'll be better.
Which is why it would be helpful if there is some kind of commonality to people becoming damaged by it or reacting badly to it, that we should know.
Absolutely.
And then you can make a decision. Like, for example, with children who we were told were never going to need to be vaccinated, but we now are told should be. For parents wanting to make that decision, it's very tough, because you say, well, hang on, how do I know that it's not going to have a bad effect on my 12-year-old or my 13-year-old? And nobody will tell you. Yeah.
So, I mean, from what I've seen, the children who've done unwell with COVID have been children who've had a medical history, who've got obesity, have got other complications. And we've always seen that there's a huge differential in the age profile. The average person who dies with COVID is 83 years old. The average person who dies in this country is 82.
And obviously February is looming very large. I've been given a piece of information in which it says that GP practices are now going to be able to basically access vaccination information on their employees, and if you have an employee in your practice who is not vaccinated, you might be asked to provide a different exit and entrance door for them to come in and out. Are you worried that the NHS is kind of becoming a bit Orwellian here? Well,
a separate entrance would be fairly minor compared with being fired. So, if I haven't proved my vaccination status as being double vaccinated by the end of March, I'm going to be fired.
Yes. Is it only the case, though, that if you're front line, so if you're in the back office somewhere in a hospital, you're okay?
So admin staff, people who come onto the ward, people who work in kitchens, they're also going to be fired.
Right. And so how did you come to be in that same space as Savid Javid that day? Because that's a question a lot of people have asked me, because, of course, they think that there was some kind of mad conspiracy going on. Was it pre-arranged?
No, I mean, it was my standard day to be on one. I was starting a week of on-calls on the intensive care unit. We'd come in as usual, had the handover from the night team, gone to our sort of bed meeting, and at the bed meeting it was announced that Savid Javid was making a visit, and he was going to make a visit to one of the other critical care units and then come to my unit. So, when he was announced that he was arriving, I was there. I met him with my clinical lead as he came into the unit. We had a brief conversation about how it was during the pandemic, and then he walked over to talk to the nurses.
Right. And they seemed almost kind of slightly embarrassed about the question that he asked them, was, how do you feel about the vaccine mandate? And they all looked to me as though they would have said what you said, but didn't want to.
I don't want to comment on how my colleagues felt. I think that when you review the video yourself of their responses, people make their own minds.
Right. And would you say that there are quite a lot of people then in your knowledge, I'm not going to say in your particular hospital, who have not been vaccinated and who will be out of a job then?
Yes. I've been contacted by a lot of people over the last 10 days from all over the country. A lot of people are saying, the majority of people are saying they're going to quit because they can't stand this idea. Right. And a few are saying they're going to reluctantly take the vaccine because they cannot see another way to pay the bills.
And if that is the case, presumably all hospitals will be affected by people who are no longer working there.
Yeah, so we are looking at, I think it's about 80,000 members of staff, about 5% roughly of the NHS workforce. And we're not talking about those members of staff who work in other CQC institutions like private institutions, because it counts for them as well.
Right.
And they're going to be out of a job. We've currently got a job vacancy list of 100,000 people, so we're almost doubling the vacancy list overnight.
Right. And is there any chance, do you think, that they'll reverse this policy, that they'll suddenly go, actually, we just really wanted everyone to get vaccinated and that was why we did it?
Well, I think if people are asking what the public think about it, and the popularity of a policy often counts. It often carries a lot of weight. I'm seeing a hugely positive a hugely negative response towards the mandate itself, and a hugely positive response to those of us who are speaking out against it. Because the public can make sense of is it a good idea in a health crisis to sack 5% of your workforce?
No, doesn't seem to be. But are you saying that you've actually been more encouraged by the reaction to what you did rather than discouraged? I mean, what was the King's College's reaction, for example?
So from the management at King's, I've had no influence and nothing negative. There was normal conversation after I'd had the conversation with Savid Javid, so I've not got any bugbear there.
Okay.
Amongst my colleagues, by speaking out, I represented a group of staff across the country who haven't been heard their voice heard. So I was representing them, but I was not representing my department. So people saw me as a representative of the department because I was, in uniform at the hospital with my name underneath and King's College Hospital, but I wasn't speaking on behalf of the department. So I can understand that my colleagues felt that what I'd said wasn't fair.
Yeah.
And I think their main concern was that I put across a point of view that didn't convey my own feelings and their feelings about the benefits of vaccines.
Right. So you weren't a pariah. I mean, because you know as well as I do, I don't probably have to name who they are. There were quite a few sort of active, shall we say, medics on social media who are very pro-vaccination, very pro-lockdown, very anti anybody being a dissenter from that view, and that would include me and presumably would include you. So you haven't been turned into a sort of, hate figure by the medical establishment.
Well, I think I've been that for some people, but I don't tend to look through those channels. For me, I've got to look to myself as to whether I'm true to myself and stick with my own opinions rather than be worried about what other people say.
It's a fine but very old-fashioned view these days, because for a lot of people it's been quite difficult, I suppose. I mean, many people wouldn't have the courage to stand up and say what you said simply because they'd be worried about the consequences.
Yeah. For me, it was just a question of here's an opportunity to say something. I don't mind going on the record. I'll do it.
And as a result, of course, the Daily Mail did a big piece on you and your wife saying that you're all a bit odd. Apparently she's involved in yoga.
Yes, I know.
Something they don't encourage at the Daily Mail.
No, I don't know whether the journalist has read the rest of the Daily Mail or not, but we also do terrible things like cycling at the weekend.
Well, I'm against that, obviously.
And I've been on holiday as well. So
have you?
Yeah.
Goodness gracious. Well, where did you go that you couldn't, where you could get in?
A Danish island, apparently.
Oh, brilliant. Yeah. Excellent. So, I mean, as far as your kind of next move, I know you also have a private practice, and again, some people, when I said you were coming on, were like, well, he's just going to go off and work in his private practice, he doesn't care about the NHS. Well, most people in the NHS, as far as I know, seem to have a private practice of some kind or another, so I'm not going to castigate you for that. But if you are out of a job, will you have that private practice to fall back on?
I'm not allowed to do private practice if this mandate comes in.
Oh, so you can't actually work in the system at all?
The mandate stops anyone who's working in a CQC-regulated institution. That includes all private hospitals.
Right. So what will
not be able to do any patient-facing work.
So what will you do then? How will you make a living?
There are different options for me. One is to look for employment in Wales, Scotland, or the Republic of Ireland, where at present there aren't vaccine mandates for staff. The other option is for me to work online. So one of the things I do at King's, apart from critical care, is I run what's called an exercise intolerance clinic. So I look at patients who've got unexplained breathlessness and fatigue, and I look at the wide range of issues behind why they've got their problems. That can be sleep, that can be nutrition, that can be stress, that can be childhood trauma, and that can be their sort of current exercise capacity. So I exercise test those patients. That I don't need to be present for those tests to be done, but I can review the reports, and currently I conduct that clinic on the telephone and sometimes do it as a video.
Okay.
So potentially I can still do some of that.
And if you're not vaccinated, right, you are sometimes painted by some politicians and some medical people as being a danger to the rest of society because you don't care. What do you say to those people?
I would say that we, as a society, have chosen to live where freedom and choice are very, very, very highly valued. If you walk through London, you'll see people driving cars, and cars produce pollution, and pollution causes in cities deaths.
Not for much longer if Sadiq Khan continues with his policies.
No, so then maybe it's better that we all don't drive cars, because we also then are potentially harming other people. So there's lots of things that we do that we've accepted as society. Now, I think what you're starting to point towards is this transmission question, And the studies aren't there within healthcare settings to show what the difference is. There's a big study from the Cleveland Clinic, which is the biggest sort of hospital system in the US, and they showed that in doctors and nurses who'd previously had immunity, there wasn't any difference in transmission between those people and people who'd been vaccinated. It's not to say that a vaccine wouldn't again change it, but the thing is that if you've got symptoms and you're a healthcare worker, you don't go to work. So the vast majority of transmissions are not going to happen by people not coming in when they're symptomatic. You then wear a mask. If you then think if you're with a vulnerable patient, you're going to wear a better mask. You're going to have good ventilation. You're going to keep a distance from the patient. There are so many factors involved.
Yes, I've always thought as well that no matter what people do, the virus spreads in the way that the virus spreads. It's not. There isn't evidence, I would suggest, that if you've stopped. If you protect yourself and if you wear PPE and you go into a hospital with COVID, or you don't spread it or you do spread it, it just does spread. It seems to spread an awful lot in hospital. It
will spread eventually. So whether it spreads with you or later on is the question. Is am I able to not be the person who I personally pass it on to you, but you will get it from somewhere else. So there's most of us think that the lockdown is what caused the sort of dropping off of the curve. But the drop-off in the curve happened before lockdown happened. So, the infection rate numbers were already dropping. So we think that lockdown happened and that brought that about. But that's just an association in time.
Yeah. Fascinating. Well, listen, Dr. Steve James, thank you so much for coming in.
Thanks very much, Mike.
Perhaps we'll get you in again because there's obviously more to say and more to be said.
Big
and
topics.
We'd love to hear from people as to what you thought of what Dr. Steve had to say. You know the number 0344 499 1000. We'll take your calls next.